Hello. The first muscle group that I'm going to be talking about is the spine and the thorax group. The first muscle that I'm discussing is the longissimus. Here's a picture of the longissimus. The origin of the longissimus starts from about right here. Half of it would be muscle and half of it would be that common tendon, thoracis, off to the transverse process of the upper thoracic vertebrae, cervicis, and capitis. The insertion is the lower 9 ribs and the transverse process down here. The actions, my skeleton does not flex, would be unilaterally, it would flex this way, shorten the muscle, back up. If you were to tie your shoes and bend over, that would lengthen the longissimus. And to tie your shoe and then to stand back up, it would shorten the muscle. So it does a bilateral extension coming backwards posteriorly. The splenius cervicis is the next group, the next muscle. And I'll show you a picture of it. I have my muscles labeled right here. So this was the longissimus. It's the longest muscle of your erector spinae group. And it comes all the way down to your coccyx and along the border of the crest of your pelvis posteriorly. As you can see, I have the black markings right here, the origins, and the red markings are your insertions. So this is your splenius cervicis. Right here would be your splenius cervicis. The origin is the spinous process T3 through T6. And then the insertion is a transverse processes C1 through C3. So the insertion is actually on the top and the origin is more on the bottom of that muscle. And I have that muscle labeled, if you can zoom in on that. The functional action would be to unilaterally flex the head and neck to the same side. So when you come this way laterally, it would shorten that muscle. Bilaterally, it would extend the head and neck, coming back, shorten the muscle that way. So if you're applying eardrops, if you're going to apply your eardrops to your left side, you would flex your right side, and that would shorten and put the eardrops on your left side. Or if you're rotating to change lanes in a car. Your spinalis is right here. The spinous process, upper lumbar, the origin is spinous process, upper lumbar, lower thoracic vertebrae, thoracis, ligamentum nuchae, spinous process to C7 cervicis. So your insertion's up here, your muscle is right here. This is your spinalis. And I had to tie these on because I burnt myself with the hot glue gun. So I didn't think that was safe. So it comes all the way down here. Your insertion is the spinous process of the upper thoracis, spinous process of the cervicals, except C1 cervicis. Again, this muscle unilaterally flexes, shortens this unilaterally one side. Vertebral column, same side, bilaterally, it extends, shortens, going backwards, posteriorly, the vertebral column. If you're leaning back to shoo a fly away, you're going to be leaning back, shortening that muscle. And then again, if you come forward, you'll be lengthening, stretching that muscle. And then the last one is the rectus abdominis. There's your picture right there. I have to turn my guy around. Here's the rectus abdominis right here. And the origin is the pubis crest down here and the pubic symphysis. So I have a marking because this is the linea alba underneath my rectus abdominis muscle. That goes down the middle. And then your insertion is the cartilage of the 5th and 6th, 7th ribs. So not actually the ribs, but the cartilage of them, and the 7th rib, and the xiphoid process, which is right here in the middle. There you go. You can zoom in on that. And then how we use it is when we cough, we normally come forward posteriorly, and we compress those muscles, all our organs in. Cough, vomit, defecate. We use those muscles as a functional activity. Okay. Today we're doing the pelvis, and that was pelvis and thigh. We're doing the, pelvis and thigh. We have the rectus abdominis, which is right here. The origin is the anterior inferior iliac spine, and the insertion is the tibial tuberosity. The red markings are the insertion. Black markings on my skeleton will be the origin. So the action would be to extend the knee, like in kicking a soccer ball, and flexing the hip. So flex the knee, extend the knee, and flex the hip. So extending the knee would come forward, and flexing the hip is coming forward. The functional action would be stabilizing yourself in a stationary squat, which only works the rectus femoris because it's the only one that crosses two joints. The other quadriceps muscles they all extend the knee, like in a soccer kick. And here is the rectus abdominis. You can see it crosses those two joints. The gracilis origin is the inferior ramus pubis down here. And the insertion is the proximal medial shaft of the tibia. Medial shaft is on the inside, interior. At the pes anserinus tendon. And then the functional action would be to kick a soccer ball. If you're out here in abduction, the functional action that works the muscle shortens it. This would be stretching it or lengthening it. And then shortening it would be to bring it in, adduction, kicking a soccer ball. Or like the ice skate crossover step. That's the muscle right there. And then the other ones would be your tensor fasciae latae. I have to move it back this way a little bit more. Get in that foot. The origin is the iliac crest posterior to the anterior superior iliac spine. This is posterior. Back in here. And this is your, it's labeled there, your tensor fascia latae. And then the insertion is the iliotibial tract. So it's just a tiny little muscle up here, and then it runs down. It has a tendon that runs down, continues. It like blends in together. The action is flexion of the coxal hip. So flexion of the coxal hip would be up here, flexion. And then medial rotate again would go inwards, going internal this way, not out, in. And then abduction of the coxal joint. So this is abduction here. Just has a little bit of an abduction movement. A functional action would be to lift a leg to climb into a car. So you're lifting your leg, you're flexing that coxal joint, and then to climb into the car, you have to flex, medial rotate, and abduct and adduct the hip. Abduct the hip. And that's what it looks like. The bicep femoris is on the back side. Here's the bicep femoris. It's labeled there, if you can zoom in on that. I already zoomed in as far as I can on mine. The origin is the long head ischial tuberosity, which is right here, the butt bone, and I marked it with a black marker right there. The short head would be the lateral lip of the linea aspera, right down in here. I marked it again with a black marker. And then the head of the insertion is the head of the fibula. Fibula is here, and there's a red marking down there to see where it attaches. The action would be to flex the knee, which would come back, flexion, and then laterally rotate a flex knee. So if this is flex, then it can laterally rotate, and it would turn that way, like that, out to the side externally with the flexed hip at the tibiofemoral joint. Long head extends hip, coxal joint. Long head assists, laterally rotate hip, coxal. Tilt pelvis posteriorly. So if you're tilting posteriorly, your butt is actually tucking to rotate that hip anteriorly. Some of the functional action would be running while kicking your butt, doing butt kicks as you're running, while you're playing tag with your childhood friends, or getting together with adults just wanting to have fun. Thank you. And that's what the bicep femoris looks like. Okay, our third group is the lower leg and foot. The first muscle is the gastrocnemius. We have back here the gastrocnemius is the superficial muscle of the calf, and it's labeled there. The origin is the condyle of the femur, so that's marking up here, posterior surface. The insertion is the calcaneus, here. The red marking is the insertion, and the black marking, these two black markings here, so you'd be able to see them, are where the gastrocnemius has its origin and the muscle, and it's labeled. And it flexes the knee, comes back posterior is the flexion. It plantar flexes the ankle, where it comes down, like you're planting your toes in the dirt at the talocrural joint. And this is the tibiofemoral joint up here. And then the action is to stand on the balls of the feet or toes, more of like up here. That would be, you were contracting, shortening this muscle here when you plantar flex, to reach up into a cupboard to get like a cup or a plate. And here's a better picture. And then your tibius anterior, anterior means on the front side. Let's turn my guy around. And I have his label here. Tibius anterior. Right there, the yellow string. And the origin is the lateral condyle of the tibia. So it would be on the condyle of the tibia. There's a black marking right there for the origin. The proximal lateral surface of the tibia, and it's the proximal. And I did a black marking here on the lateral side of the tibia. And the interosseous membrane, which is between the fibula and the tibia. And the action is to invert the foot, means to turn in, rotate in, which would go like, here's your foot, and invert. And dorsiflex would bring the toes up. Dorsal means the back side, and underneath would be your front side of the foot. Anterior and dorsiflex ankle at the talocrural joint. You could do this like putting on socks if you cross your leg over, because everything is a multi-actional function, not anything unless you're isolating that muscle by exercising it. When you're actually doing your daily functional activities, it's a multifunctional move that involves many muscles on many planes and many axes. So you'd have to rotate your leg on top of your other leg if you were sitting down, and then you would invert your foot and just turn it up a little bit so you can reach your foot and then come forward to pull your sock on or your shoe. And that's the muscle there. See, it has black markings just like I did on my skeleton. And the black markings are the origins, red markings are the insertion. So the insertion would be your medial cuneiform and base of the first metatarsal. Your hallux is your first metatarsal, and your medial cuneiform would be basically one of your and it's on base right here. One of your medial, and then middle, and then lateral. It might be easier to see on here. So medial cuneiform of the hallux. Let's see. Next one is your extensor digitorum longus, the lateral condyle of the tibia again, up here, the proximal anterior shaft of the tibia, down here, the interosseous membrane, and that's between your fibula and your tibia, and your insertion is the middle and distal phalange of the second through fifth toes. And since it's extensor, it's going to be on the dorsal side of your foot, not plantar. And second through fifth toes would be right after. This is your first, second, third, fourth, fifth, and second through fifth toes. So it goes all the way out to your digiti minimi. And it's, yep. And there's another picture right there. Shows the origin with the insertions. The action would be to extend the foot, so that's like straight out, not dorsiflex, that would be up, and plantar flexion is down, so it's to extend just straight out. It does dorsiflex, which goes up, and it everts the foot, which, if this is your foot, evert would go out. Invert, evert. And a functional action would be during the swing phase of your foot. So we're in swing phase. You're pointing your toes out. You don't want them down because you'll scrape your toes. To clear the ground with your foot when you're walking. And the lower leg and foot, the extensor digitorum brevis, the origin is the dorsal surface of the calcaneus, which is right up in here. That's your talus, and this is your, over here on this side is the dorsal side of your calcaneus. And I marked it with the black marking, hoping you'd be able to see it. And here's the muscle right here, the extensor digitorum brevis. It extends 2 through 4 toes at the metatarsal phalangeal interphalangeal joints. The insertion is the second through 4 toes via extensor digitorum longus tendon. So I did the insertions here with red markings. The functional action would be, again, to put on your socks or stabilization when you're balancing on one foot. Like my guy here is tilted. So he's trying to balance on one foot. But again, you can do the extend the toes to put on socks. And again, so that's the dorsal side right there. And that's the talus. That's pretty big. But on the back side, on the plantar side, all you can really see is the calcaneus. But here, up here is the calcaneus. And that's 2 through 4. 1, 2, or I'm sorry, 2, 3, 4. And that's number 1, number 5. And today we are doing the shoulder and arm. The first muscle is the pectoralis major. The origin is here, medial half of the clavicle. This is medial. I did it in black marker again. Here's my pectoralis. It has a superior, middle, and inferior. Also for the sternum, I marked the sternum here. first through sixth rib. The insertion is the greater tubercle of the humerus, which would be right back in here, and I marked that's a separation right here, the greater tubercle of the humerus and your pectoralis muscle. It adducts the arm, which brings it in internally. Medial rotate, internally rotate, turns the arm in. The glenohumeral joint elevates the thorax, inhalation, arm fixed. Upper fibers flex the shoulder, that comes forward anteriorly. Horizontally adducts. So if you're here at 90, horizontally adduct would bring that again, bring it in anteriorly. And at the glenohumeral joint, lower fibers extend the shoulder. Lower fibers extend the shoulder backwards. And the functional action would be to swim in all strokes. And they do swimming in physical therapy as well. We have a pool inside San Juan Regional Medical Center. And you could do like the breaststroke, the butterfly stroke, the backstroke, and the forward stroke. That's your muscle, your insertion, and your origin. The next one would be the bicep brachii. The long head is the supraglenoid tubercle of the scapula. They're all right here. You have one at the coracoid process right under here. You have another one at the glenoid right here at the capitis. Short head at the coracoid. This is the short head at the coracoid scapula, and then the supraglenoid tubercle of the scapula is right in here. And then the insertion is the tuberosity of the radius and aponeurosis bicep brachii. That would be down in here, and I marked that right there. That's the tuberosity of the radius. And the actions would be flexion of the elbow, the humeral ulnar joint, supinate the arm, that's how his arm is right now, is the supination at the radial ulnar joint, flex the shoulder, it does flexion up at the shoulder, glenohumeral joint. The functional action would be holding an infant in a cradle position like this. You're flexing your elbow, and even if you want to bring your baby up to kiss, you're flexing your shoulder and your arms are in the supine position. Origin, insertion. And then we have the deltoid, bicep brachii, the pectoralis major and the deltoid are both antagonists to itself. And we have the deltoid muscle. It's labeled right here. You can see that. And then the origin is the lateral side of the 1/3 clavicle of the acromion. It's right here. That's the lateral side, outside. Acromion spine of the scapula, that's right in here. The clavicle bone is attached to the scapula at the acromion joint right there. And then the insertion is the deltoid tuberosity. It's right in here. Again, marked it with red marking. The action is abduction of the shoulder, which would bring the shoulder out. laterally at the glenohumeral joint. Anterior fibers flex. They flex. Medial rotate inward and horizontally adduct, which would bring it in. It's horizontal, bring it in. At the glenohumeral joint, posterior fibers extend, laterally rotate, coming out to the side, and horizontally abduction. This way, out, away. The shoulder at the glenohumeral joint. The functional action would be to slip your arm into a jacket. I think that's the one that I messed up on when I was thinking rotation, but it was hard to explain slipping a hand into the jacket because it's a multi-actional activity. You can't just isolate it with just that one. I guess the deltoid would have been a better one because the deltoid extends, laterally rotates, horizontally abducts the shoulder. Flexes, medial rotate, horizontally adduct the shoulder. Abduction of the shoulder. So the deltoid probably would have been a better example of slipping your arm into a jacket. Sorry about that. I didn't know how to explain it because anyway. Yeah, that's what I did there. And then lastly, see his little booty, little coxie, would be the rhomboid major. The origin spinous process is T2 through T5. So we have the rhomboid major right here, labeled right here. And this is the medial border of the scapula. So insertion is the medial border of the scapula between spine and the scapula and inferior angle. This is your inferior angle down here. The rhomboid major, it has the scapula adduct, which is closing it in together. And then elevate, going up the scapula, and downwardly rotate the scapula downward. The scapulothoracic joint. The functional action would be pulling your shoulders back to stick out your chest for good posture for your rhomboid major. Bringing the scapulus together on adduction. And that is your origin and insertion. And that's it. Thank you for listening.